Hi, my name is Anthony Rehil-Crest, and I was invited to give a talk about medications for opiate use disorder. So that's going to be the subject I'm going to talk about today. So thanks for inviting me to this summit. So the agenda for today is just to kind of give a general overview of the medications that we use to treat opiate use disorder. So I'm going to give kind of a general background, a little bit of a history of using these medications, talk a little bit about the pharmacology of these medications, how they work, and then kind of go through the various stages on starting people on medication, specifically buprenorphine, going through the assessment and the initiation, the induction, the maintenance, and then touch upon some common issues that have come up in my practice since I've been prescribing buprenorphine, that are common questions that I get. Go a little bit over the documentation and coding when you're seeing these patients, and then talk a little bit more about resources for more training, and then hopefully you'll have some time for questions afterwards. So my background, I work at Heritage Health, which is a clinic here in North Idaho. I'm a physician by training. I'm currently the chief clinical officer at Heritage Health, and I've been practicing medicine in North Idaho for 10 years and prescribing buprenorphine for opiate use disorder since around 2016. Heritage Health is a primary care clinic, but also offers a number of services under one umbrella, including psychiatric care, dental care, counseling, and substance abuse treatment. So we kind of have everything under one umbrella. We are probably the largest primary care clinic in northern Idaho. So just stepping into the background on medications to treat opiate use disorder, I wanted to first talk about terminology. Terminology and how and sort of vocabulary has changed recently when we're talking about people with addiction and substance use disorder, and it's important to touch upon because there's quite a bit of stigma associated with substance use disorder, and using the correct terms helps kind of decrease that stigma that patients feel or shame that people feel about this disorder. So when I'm talking or classifying patients who have addiction, we're usually trying to use the term substance use disorder rather than addict. So in this sense of opiate use disorder, we use opiate use disorder or alcohol use disorder or any whatever drug that they're having issues with. So for example, benzodiazepine use disorder would apply to, or amphetamine. We use the term medications for opiate use disorder, or MOUD. We used to use the term MAT, or medication-assisted treatment, but several years ago this has changed, so you'll hear me using MOUD rather than MAT nowadays. Tend to try to use terms like intoxication or intoxicated rather than saying high, or the patient was high on their drug. And then trying to use terms like recovery or long-term recovery instead of history of addiction or history of being an addict. So there are three medications that are used to treat opiate use disorder. Those are methadone, naltrexone, and buprenorphine. Naltrexone is an oral medication, but also comes in this medication called Vivitrol, which is injectable, which is relatively new on the market for treating opiate use disorder. But these are the three main players that we use for treating opiate use disorder in terms of medications. It's important to note that methadone can only be prescribed in an opioid treatment center, or what we commonly call methadone clinic. We can't prescribe methadone as a primary care provider in a primary care clinic. This talk is mainly oriented to primary care providers, physicians, PAs, and NPs, and how they can start prescribing this medication in their clinic. So that's important to note, that we shouldn't be prescribing methadone outside of a methadone treatment center. For opiate use disorder, you can prescribe methadone for pain, but if they need it for opiate use disorder, they should be prescribed at a methadone clinic or opioid treatment center. The pharmacology of MOUD is interesting, and if we take those three medications that I talked about, they all work in different ways. And I'll go into the details, we'll go into a little bit more. The reason, the pharmacology behind buprenorphine is the reason that we can prescribe, as primary care providers can prescribe it outside of a opiate treatment center. And I'll go into that here in a second. And so the three medications, methadone is considered a full agonist, and the naltrexone is considered a full antagonist, and buprenorphine is a special class of medication they call partial agonists. And to illustrate that a little bit more, this is a graph that maybe some of you have seen in your training that illustrates how a medication has an effect based on its dose. So on the x-axis is the dose of the medication, and the y-axis is its effect on the person that taking the medication. And pretty simplistically, you know that a full agonist like morphine or methadone or hydrocodone or oxycodone has full activity on the receptor. So when you increase the dose of the medication, you get more activity. The patient has more of a pain relieving effect. They have more feeling better or euphoria as you increase the dose. On the same token, they will also have an increased effect from side effects from the medication. So as you increase the dose of methadone or hydrocodone or oxycodone, they may have more side effects that come with opiates in this sense. So more constipation, more chance of respiratory failure or lethargy or things like that. And then on the flip side is naltrexone, which is a full antagonist, which as you increase the dose, really nothing really happens in terms of effect. It's an antagonist. It does not activate the receptor. You can keep increasing the dose. It won't cause any effect except to block the opiate receptor. And in the middle, we have this something called a partial agonist, which is, in this case, we're talking a lot about buprenorphine. Buprenorphine is a partial agonist, which means it activates the receptor somewhat, but also serves as kind of a blocker of the receptor at the same time. And what happens when you increase the dose of a partial agonist, there's this initially an increase of the effect, so they get the effect from the opiate, but at some dose, and it depends on the type of partial agonist, at some dose it stops creating effect and it kind of plateaus. And then increasing the dose no longer increases the effect, and increasing the dose doesn't really cause any increased side effects. And that's really the reason why we're allowed to prescribe this medication outside of a methadone clinic or opioid treatment center, because of this pharmacology makes it a very safe medication to prescribe. It is very hard to overdose on buprenorphine, unlike methadone, where if a patient were to take, say, a week's worth of methadone in one day, they might cause an overdose. Because of this partial agonist effect, it's hard to overdose on buprenorphine. It's also hard to get intoxicated on buprenorphine. It's hard to misuse it and get intoxicated. And so that's the main reason why we are allowed to, as primary care providers, to prescribe this in our clinics as opposed to methadone. Partial agonists are not new to medicine, and you probably are already prescribing some of them. Another popular one that we use is a medication called Chantix or varenicline. It's a partial agonist of the nicotine receptor, one of our best medications to treat nicotine addiction or get people to stop smoking. So it's not a new type of medication. It's just one that we are kind of, that works well in this scenario. So buprenorphine, as I said, we're going to focus mainly on using buprenorphine to treat opioid use disorder because that's what we can use in the outpatient setting. So there are multiple formulations. So there's buprenorphine tablets. There's buprenorphine tablets mixed with naloxone, and then there's the films that come in. Those are mainly three oral formulations of buprenorphine. The buprenorphine only tablets are also sold under the brand name of Subutex. You may hear patients refer to them as subs. The buprenorphine and naloxone films are also sold under the brand name of Suboxone, but they are also generic, as well as the tablets. All these formulations are sublingual, so they can't be used orally. You can't swallow them. They have to dissolve under your tongue or in your cheek for them to work. There is a subdermal implant, however, it was called Probufene, but I believe the last time I checked, this is now off the market. It came off the market sometime during the pandemic, so I don't think that's available anymore. Then there's a third type of formulation called Sublocade, which is a depot subcutaneous injection of buprenorphine. This is a medication that's injected once a month to the patient. It's a very effective medication. The downsides of it is that it's very expensive. I know that North Idaho or Idaho Medicaid does pay for this medication. The other complicating factor of this medication is that it can't be dispensed to the patient. It has to be dispensed to the provider. So the provider has to have a way of receiving the medication securely and actually storing the medication securely. So that makes it a little bit complicated in terms of administering this medication. But it's a very good medication if you can get it paid for and also get it arranged for it to come to your clinic to be administered. So most of us, when you're prescribing buprenorphine, you'll be using the oral formulations or the sublingual formulations, the tablets or the films. So why is there a combination product? Why do we have this buprenorphine alone, and then why do they mix it with naloxone? And the reason is because buprenorphine does have an intravenous misuse potential. So there is a potential for people to take buprenorphine, dissolve it, and then try to inject it to try to get intoxicated from it. It's not as, because of that partial agonist effect, it's not nearly as sought after as, say, injecting heroin or methadone or hydrocodone, but it does have a potential to be used in an intravenous fashion. The naloxone mixed in with the tablet only becomes active if you inject it. It's not active. It doesn't dissolve under your tongue, so it can't be activated that way. So the reason the naloxone is there, if you try to dissolve it and you inject it, the naloxone will become active, and then they will go into opiate withdrawal very quickly, and it'll make them very sick. So the reason we mix the naloxone in with the medication is because it decreases the risk of diversion, the risk of people selling it. This is a study that was done now it's looking probably like 6 years ago, where they tried to measure how likely the formulations were diverted or sold on the streets, and the buprenorphine tablets is over 6 times more likely to be sold on the streets than the medication mixed with naloxone. So it has a much higher street value, much more likely to be diverted because of that. So because of that, the combination product really is the standard of care when you're treating people with opiate use disorder with buprenorphine, is to use the combination product so that it is less likely to be diverted or misused. Do I have patients who are on buprenorphine alone? Yes, it's a handful of patients, and usually those patients had some sort of adverse reaction to naloxone. But far and away, majority of my patients are on the combination product. So the phases of care, I'm going to go through those and kind of initiating care for a patient going from their opiate that they're abusing onto buprenorphine. And so those phases are screening the patient and then talking about initiation, induction, stabilization, and maintenance. So the screening initiation, so first, of course, you're going to be determining if the patient's appropriate for buprenorphine, and that's going to be taking a very comprehensive history about their substance abuse, their current and past substance abuse. There's also, and as most of you are probably already do, you're screening your patients for mental illness, specifically depression, anxiety, and then also severe mental illness like bipolar disorder or schizophrenia. That's important because many of these people may have co-occurring psychiatric or mental illness, and you may need to involve a psychiatric specialist to try to treat them as well during their treatment. Many of these people may have been because of their opiate use disorder, they've not been getting treatment for their bipolar disorder or psychotic disorder, and it's important to involve that a specialist if you need to. Then a comprehensive medical history, of course, is important. Make sure that it's appropriate for them medically to be on buprenorphine. They don't have any medications that would interact with buprenorphine, or any medical problems that would interact, or that would be contraindication to buprenorphine. Do they have severe cirrhosis or liver disease or kidney disease? Those are important things to know too. And then I often offer my patients testing for or screening for common things like HIV, hepatitis B, and hepatitis C, which of course, given that they have a substance use disorder, they're at increased risk for having those conditions, and you would want to know that before you begin treatment, because certainly there are some cases with HIV where medications that treat HIV interact with buprenorphine, and also potentially with treating hepatitis C and hepatitis B. So the induction is the phase where we're switching the person from their opiate of choice that they're abusing or misusing to buprenorphine, and this is, and sometimes in some ways, the most nerve-wracking process for the provider and the patient. The patient's main concern is if they're going to go into withdrawal, they want to try to avoid opiate withdrawal, and the same with the provider. They're going to want to try to avoid the patient going into significant opiate withdrawal. So the specific goals is to find a dose that works for the patient. Every patient is different for how much buprenorphine controls their cravings, and also decrease the risk of getting withdrawals from opiates, have minimal side effects, and then also eventually, once you're in the maintenance phase, you're going to be dosing the medication to decrease their cravings for opiates, which is generally how you dose the medication. So before you're starting to prescribe buprenorphine in your practice, it's important to have a number of kind of logistical things in place in your practice, which most of the time, if you're practicing primary care, you probably already have those things in place. But it's important to make sure that you have that in place before you start prescribing buprenorphine. So some of those things I'm sure most people have is that you have point of care urine drug testing. Most of you in primary care are prescribing opiates or other controlled substances for medical issues, so you probably already have point of care drug testing in your clinics. But it's also important to make sure that your point of care drug testing does test for buprenorphine, because one of the things you're going to want to be testing for is if the patient's taking the medication. And most of them do nowadays, so that's usually not a problem. You also want to make sure in your community you have a pharmacy that carries buprenorphine. Most pharmacies do nowadays. I would say 5 or 6 years ago, it was a little bit hit and miss, but that's usually not an issue anymore. But making sure that you have a pharmacy that carries this medication. Making sure that that you have some sort of access to substance abuse counseling. Certainly, most of these patients would benefit, if not all, would benefit from some substance abuse counseling. So making sure that you have some referral source or access to that. Many of these patients may have co-occurring substance use disorder, so they may not only be abusing opiates, they may be abusing methamphetamine, and obviously buprenorphine does not curtail someone's cravings for methamphetamine, so that person would be appropriate to refer to a substance abuse counselor. And quite frankly, for a lot of these patients who may be abusing opiates for years, the only people they know are other people who abuse opiates. And so substance use counseling helps kind of reorient these people back into society and try to get them back into meeting other people who are in recovery, how to get back into getting a job, getting back into the normal life. So that kind of, the substance abuse counseling does help a lot with that. So I do refer all my patients to that when they come and see me. Insurance issues, so that's less of a factor nowadays. In the past, there was a question of whether insurance would cover buprenorphine, but nowadays most insurance plans will cover buprenorphine, including Medicaid. Even patients who are uninsured buprenorphine/naloxone is now generic, and it's actually pretty affordable for people who are uninsured compared to maybe 5 or 6 years ago. It was not generic and it was very expensive, but that usually is not much of an issue in these days. So location, when you go through kind of waiver training, things like that, they talk about the difference between office induction and home induction. On office induction is where the patient fills a prescription for buprenorphine, they bring it back to your office the next day, and then you go through the induction process in your office. And the home induction really is similar, except that you spend more time educating the patient in the office. They pick up the medication at the pharmacy and do the induction at home. I would say for the majority of people who prescribe this medication in the primary care setting, office induction is just not done anymore, just because of the logistics of doing an office induction in the course of a day. It usually takes several hours of having the patient take the medication, observe them for a couple of hours, take more. It's just not logistically feasible in the course of a primary care practice. And most surveys nowadays show that a majority of people are doing home inductions, and most research shows that home induction is just as safe as an office induction. So all of my inductions are done at home, and it's just a matter of giving the patient proper education, which I'm going to go through here in a second. So home induction starts with, once you've identified the patient is appropriate for buprenorphine, it's really about educating the patient about using buprenorphine/naloxone, how it works, how it's absorbed, how you take it. Those are really what I'm spending most of my time with, and how, in terms of like how you administer the medication to yourself. And so generally what I'm doing is I'm writing them a short prescription for buprenorphine, usually like 3 or 4 days, which is when I want to see them back in the office after the induction. I'm spending a lot of time talking about how they take the medication, how they put it under the tongue, they let it completely dissolve, try not to talk when it's dissolving, try not to swallow the pill, those kind of things that I'm going through. And then I'm talking to them about when they can start the medication, and the timing is important in starting buprenorphine because they want to start the medication when they're going through withdrawal. If they start the medication too early, they can of course have a precipitated opiate withdrawal and they become very sick. So part of that is the timing is depending on what opiate they're abusing at the time, whether it is a long-acting opiate or a short-acting opiate. So it's getting that history and also checking that urine drug screen to see what they're taking. So for most people who are using like a short-acting opiate like heroin or oxycodone or hydrocodone, they'll generally start going withdrawal within 12 hours, and that's usually a safe window for them to start taking buprenorphine. For people who are on a long-acting opiate like an OxyContin or MS-Contin, it might be over 12 hours, 18 to 24 hours before they can start buprenorphine, before they start going in withdrawal. And then methadone is a special case, which I'll go over very briefly, but that, because of methadone's metabolization, it can be a little tricky. That's a very long-acting opiate. So usually what I tell patients is when they go home, they get their buprenorphine, they're ready to take their first dose, that before they take their first dose, they should be experiencing some mild to moderate withdrawal symptoms. And I don't usually have to explain what that is to most patients, because most of these patients know exactly what it's like to go in withdrawal. They have a long history of opiate use. They know what withdrawal feels like. They usually know when they're going to go in withdrawal based on their last dose of their opiate that they're abusing. And so what I usually say is, once you're in opiate withdrawal, you're going to take about 2 milligrams or 2 to 4 milligrams of buprenorphine, let it dissolve under your tongue. And then you're going to want to wait probably an hour, a couple hours, and kind of self-assess how you're feeling. And mainly what you're self-assessing is where you are with your withdrawal. Some of the withdrawal symptoms are going to get better, if not completely go away. But if they're still kind of feeling like they're in a state of withdrawal, then I'll go ahead and say you should take another 2 milligrams of 4 milligram dose and see how you feel. And again, and then wait 45 minutes to an hour, reassess, see how you're feeling. Generally, for the first day of home induction, we want them to not go more than 8 milligrams of buprenorphine. So some patients will only need about 4 milligrams. Some people will need 6 milligrams. It depends how they're doing. Then the next, this is a little more into the education on how to take it. So this is just some brief education on how to dissolve the medication out of their tongue, and then I will go into a little bit about this. This is something from your training too that you may have done in a waiver training, is the clinical opiate withdrawal scale. These are just the signs and symptoms of opiate withdrawal. Again, I don't specifically go through this scale because, as I said, almost all my patients, when they come to me, they know what withdrawal is and they know when they're in mild to moderate withdrawal. So I usually don't have to go over this with them. So we've done day 1 of the induction, where they've kind of given themselves a small doses of buprenorphine to kind of take care of the withdrawal symptoms, and then they end the day at maybe 4 to 8 milligrams. And then what I tell them is then the next morning they wake up on day 2, and they basically take whatever they ended up with on day 1. So if they got by with 4 milligrams, they should start the day with 4 milligrams. If they had to use 8 milligrams, start the day with 8 milligrams. And then again, just kind of give that a few hours, see how you feel during that day. If you need to take an additional dose to help with withdrawal symptoms, you can. And then over the course of those day 2, day 3, they may stabilize themselves at around somewhere between usually 8 and 16 milligrams of buprenorphine per day. I do usually tell them that it takes about 5 days to reach steady state. So they may still experience some mild withdrawal symptoms in those 5 days. So it's not going to be by day 2 they're going to be feeling completely normal, but it may take a week or so for them to kind of reach a steady state with this medication. So basically the patient in this home induction scenario are really assessing how they're feeling after taking some small doses of buprenorphine, and then usually by day 2 or day 3, they've kind of found which dose they're going to be at, which typically is between 8 and 16 milligrams. And then what I usually do is see them shortly after that, so maybe 2 to 3 days after they've done this home induction. Kind of see how they're feeling, and then we're kind of working our way into kind of stabilization and maintenance. Most patients will not need more than 16 milligrams. There's some patients who will need a higher dose, 20 to 24 milligrams. Most insurance companies will not pay for more than 24 milligrams. So that really is the maximum dose that you can prescribe. But I would say far and away, most patients need between 8 and 16 milligrams. And I'm mainly basing that off what if they're having opiate cravings. And so to suppress most people's cravings is usually between 8 and 16 milligrams. During these phases, when I'm seeing them, I'm always checking urine drug screens. One, and the reason we're checking urine drug screens is, one, to see if they're actually taking the medication. So I want to make sure that I'm seeing buprenorphine in their urine drug screen. And I'm also seeing if they're using any other illicit substances, because that's a way for us to kind of monitor their substance use disorder. Are they still using methamphetamine? Do we need to have a referral off to a counselor to treat their methamphetamine use disorder or something like that? Then once, I'll go back to this a little bit, but once we're in the maintenance phase and they're stabilized, then I'm usually seeing them out every 4 weeks, even for my stable patients, and again, doing urine drug screens at each of those appointments. As I talked about before, methadone is this kind of special case. And if the patient is abusing methadone, it can be difficult to transition them to buprenorphine. Generally, you have to taper them down to 30 to 20 milligrams before even considering them switching to buprenorphine. And they often have to be able to be abstinent from methadone for at least 24, maybe 48 hours before starting buprenorphine. So this can be really difficult for patients to do. I've only probably done this a couple times, and so it's hard for them to do that. Some of these patients may be better suited to go to a methadone clinic, but it can be done. It's a little more time intensive and tricky to switch them from methadone. Again, if the patient is coming to you from a methadone treatment program and wanting to taper their methadone, really shouldn't be doing that. That should be done at the methadone clinic or the opioid treatment program. We in the outpatient setting should not be prescribing methadone to patients for substance use disorder. It really needs to be done in a specialized clinic, and that's because of that risk of methadone. It's risk of overdose if it's not carefully monitored. So precipitated withdrawal, that's the big fear that patients have when they start buprenorphine. Buprenorphine, if taken too early, can cause a rapid and intense opiate withdrawal. And so that's the rationale behind waiting until the patient's already in opiate withdrawal before starting buprenorphine. This can happen. It's usually in the first few hours after a dose, but and I would say that many times I've done induction, I may have only experienced this once, where the patient took the medication too early. So giving the patient proper education on a home induction, when to take the medication, making sure they're in a mild to moderate withdrawal state before starting buprenorphine, that generally would keep them from having precipitated withdrawal. If they do have a precipitated withdrawal, there are really two options. You can give another dose have them give themselves another dose of buprenorphine, and so you're in that sense you're trying to provide enough agonist effect from the buprenorphine to suppress the withdrawal, or you can stop the induction entirely and provide symptomatic relief for opiate withdrawal and have the patient return the next time you see them. Most of the experts recommend that you do not stop the induction and have them try another dose of buprenorphine with the hope that will suppress the withdrawal. And the reason is because if you stop the induction, you're more likely they won't come back, and they won't come back for treatment. So that's what I usually tell patients. If they do think they're having precipitated withdrawal, they should contact me, and we usually can walk through that and try dosing a smaller dose of buprenorphine to kind of work through those withdrawal symptoms. Stabilization and maintenance again. So now we're kind of past the induction, kind of working on stabilizing, and then eventually you'll be at the maintenance phase. Most patients, so this is after they've kind of found their dose, so usually somewhere between 8 and 16 milligrams per day, and they're not having cravings for opiates, so they're really kind of in this maintenance phase. Usually patients will only need once daily dosing of buprenorphine, so they can take their entire day dose of buprenorphine once a day, usually in the morning or at night. Some people prefer to divide their dose into twice a day, which I do allow. I try to discourage patients from doing more than twice a day dosing, like 3 times a day or 4 times a day, mainly because that will force them to take the buprenorphine out of their home usually into work, and that makes it more likely they'll lose the medication. So if they can't take the total daily dose once daily, I'll have them take it twice daily, once in the morning and once at night. But it's meant to be taken just once a day. It's very long acting, so most patients can just take it once a day. More into administration, so films or strips, usually no more than 2 tablets should be taken under the tongue at once. And then in the maintenance phase and the stabilization phase, we're usually making small increments, increasing or decreasing the dose, mainly based off their patient's cravings. So if they're coming back to us and saying they're still having cravings for opiates, we might increase their buprenorphine a little bit until they're no longer having opioid cravings. And that's really how we're dosing the medication in the maintenance phase. And again, we're seeing these patients about every 4 weeks once they're in maintenance. Again, I'm doing urine drug screens at each appointment, again, testing to make sure they have buprenorphine in their system, and then also monitoring if they have any other co-occurring substance use disorders and trying to address those. So how long should I be on buprenorphine? This is a common question that I get from patients when we're starting it, and it's a little bit of a harder question, but I have patients who will come to you and say, I like to, I'm abusing heroin, I want to get on buprenorphine for a few months and then get off of everything. What I usually try to give patients is a realistic expectation of how long they'll be on buprenorphine. What I usually say is most patients will probably be on this medication for at least a year before they even consider tapering. Some people are gung-ho and think they're going to taper in a few months. I would say a vast majority come in thinking that might happen, but a vast majority are not able to do that. There are studies that show that getting people stabilized on buprenorphine and then trying to rapidly taper them off the medication usually leads to relapse and starting using the medication again. So we generally stabilize the patient on buprenorphine, go into the maintenance phase, and then kind of just reassess every month about where they're at. And I would say a vast majority of the patients, once they are stabilized and are on the maintenance phase, don't really want to taper off of the medication. At that point, they want to give it some time to kind of feel normal again and kind of rebuild their life since they are no longer abusing medication. And usually we're continuing this medication as long as the patient's benefiting from the medications, as long as they are decreasing their substance use, as long as they're meeting their kind of relationship and employment goals, it's perfectly fine to continue the medication. I tend to be very patient-centric when it comes to tapering and continuing the medication, so I usually let the patient let me know when they feel like they can taper. And when they do want to taper, then I usually assist them in tapering it. The tapering is usually a pretty long process, and usually what happens is we'll taper down to a certain dose, and then the patient will usually like to hang out there for a few months, and then we'll try tapering again. And so I tend to be kind of just let the patient tell me how they're feeling about when they're ready to taper. But I would say a vast majority of these patients will be on this medication for years, and many of them may be on this medication for the rest of their lives. This is just a study I mentioned about trying to taper patients off of buprenorphine too quickly. It often leads to relapse very quickly if they taper them off the medication too rapidly. So now we've gone over kind of the basics of buprenorphine, how to set it up in your clinic, in your primary care clinic, gone over the kind of the screening, initiation, induction, and maintenance phase. Now I want to go over like some common issues. These are kind of common questions that I get from my colleagues about what to do when I have a patient, say, who's already on buprenorphine, they've been on it for years. They're kind of your typical primary care patients that are coming in for things like acute pain. They may have to have an elective surgery. What do you do in those situations when they're on buprenorphine? And we have to address things like acute pain. So I'm going to go over those here real briefly. So acute pain. So this is pretty common. The more prescribing you do for people with opiate use disorder with buprenorphine, things are going to happen. They're in a car accident, they go skiing and break their ankle, sprains, strains, acute exacerbation of back pain, sciatica. All these things happen just like any typical patient that you see. So what to do with these patients? So what I do, and to step back a little bit, there's no guidelines as to what to do exactly with this patient. So these patients, mainly this is based off is expert opinion. So these are opinions from national experts about what to do with patients who are on buprenorphine and they have acute pain needs. So what's recommended is that you, of course, try any kind of non-opiate analgesics first, and that's pretty typical of anyone who's not even on buprenorphine, is that you should really try non-opioid analgesics and non-pharmacological modalities such as physical therapy, massage, anything like that to kind of help address their acute pain. If that doesn't work, if they've tried taking NSAIDs and Tylenol, we've tried non-pharmacological modalities, and they're still having pain that they can't cope with, they can't control, then what I will usually do is take their daily dose of buprenorphine and have them divide the dose into 3 to 5 times per day. So what that means is I'm not increasing the dose of buprenorphine, I'm just taking their total daily dose. Instead of taking it once a day, you're going to divide it into 2 to 3 or 3 to 5 times a day. So, for example, if they're taking 16 milligrams of buprenorphine, I may have them take 4 milligrams 4 times a day. And that's just a matter of them cutting the tablets in half or quarters, or cutting the films in half or quarters. And that surprisingly gives a lot of analgesia, or a lot of pain control for a lot of people. I've had patients fracture their ankle, fracture their other bones in their body, and I've said, instead of we're not going to take you off of the buprenorphine, just take your total daily dose and divide it into 3 to 4 times a day, and that actually gives them quite a bit of pain control. The things we want to try to avoid is taking them off the buprenorphine, and putting them on a full agonist like hydrocodone or oxycodone. And the reason is because that increases the risk of relapsing, of course. And so that's a scenario we're trying to avoid. And I would say most patients who've been on buprenorphine for a long time really don't want to go back on the full agonist because they're afraid of that they might relapse. And so kind of planning for this and talking to patients about this really helps in the beginning. And I also rarely have to increase the dose of buprenorphine. So the common phone call I get from patients is that something happened, they broke something, and so they think, well, I'm having increased pain, so I'll increase this from 16 milligrams to 20 milligrams. And I try to tell them not to do that. You really don't usually need to increase the dose of buprenorphine. You usually just need to change the way you're taking it, and that gives you quite a bit of pain relief in doing that way. I usually also had them add on maybe Tylenol or ibuprofen, so they're kind of taking this cocktail of a half a tab of buprenorphine, a full dose of ibuprofen, and a full dose of Tylenol, and doing that 4 times a day also gives them quite a bit of pain relief that way. And then once their acute pain has resolved, then I usually just have them go back to their once a day dosing. And so once whatever injury has happened and the pain's got back down to normal, just go back down to once a day. And that's worked for me. I wouldn't say it's every time, but it's worked most of the time when I've done this. And rarely do I need to increase the daily dose of buprenorphine this way. I will say though, if they happen to be they're on a really low dose of buprenorphine, so let's say they're not on 16 milligrams, let's say they're on like 8 or 6 milligrams, I might increase them a little bit for their acute pain crisis, but then go back down to their standard dose. So elective surgery, the more you do this, longer you do this, this will come up a lot, and it's mainly because now these patients are stabilized on buprenorphine, they got their lives back together, they're employed, they have health insurance, and now they finally want to get that knee replaced or their hip replaced or something like that. And so this comes up a lot. And so what do we do with these patients who are going to have this elective surgery that's going to have some postoperative or perioperative pain? So the first thing I do is I tell the patient to let me know if anything is coming up. And so it's like, and I tell them to say, if you're going to have surgery, if you're going to have a knee replacement, please let me know so we can make a plan. Because that's the most important thing, is making a plan with the patient about what their pain control is going to look like following the surgery. The goal, again, just like in the acute pain scenario, and this is again is expert opinion about what to do, is our goal is really to keep them on buprenorphine. And the reason is because if we take them off buprenorphine, there's a high chance that they'll relapse. And so our goal really is to try to keep them on buprenorphine throughout the surgery. The next thing I do is I almost always will call the surgeon. And that's usually to kind of sync up our plan. So I usually will talk to the surgeon about the patient that I have them on buprenorphine. I usually tell them that my goal is to keep them on buprenorphine and make sure that's okay with the surgeon from his standpoint. Most of the time the surgeon is fine with that plan. What I usually talk to the surgeon about is what we're going to do kind of perioperatively and postoperatively with their pain. The surgeon is usually concerned about what to do in the immediate postoperative phase if they have pain. And usually what I do is I tell them they can use intravenous opiates like fentanyl and things like that in the immediate postoperative phase to treat their acute pain. But then I usually request the surgeons discharge them just on their buprenorphine. And then I will usually see them shortly after surgery and manage their buprenorphine and their pain after that. And again, it's using that kind of acute pain pathway with buprenorphine where I'm taking their total daily dose and dividing it between 3 to 5 times per day, and that's usually giving them enough pain control postoperatively to keep them comfortable. And so, I would say all the times I've talked to a surgeon about one of my patients going through elective surgery, they're very appreciative that I called them and sort of set up this plan. So I encourage, if you're going to do this, call the surgeon, tell them what you would like to do, making sure that they're okay with that. If they have questions about what to do with their immediate postoperative pain, I usually tell them that they can give them intravenous fentanyl in the hospital, but discharge them just on the buprenorphine. Then I usually try to see them very shortly after the surgery. That's just what I just talked about. So yeah, you can give IV fentanyl that will overcome the blockade that buprenorphine gives. I also, if the surgeon is able to, if they can use any other sort of ways of blocking pain during the surgery, using nerve blocks if they can, things like that. That's also helpful on that end too. And then discharge patient back on buprenorphine. So those are the two most common things that come up with me in buprenorphine, those acute pain and surgery, elective surgery issues. Most of the time we can easily work through a lot of those. So coding and documentation. So this is a common issue too. So when I'm seeing these patients in the clinic for treatment with buprenorphine, what am I documenting? What am I coding? So the coding that you're going to use mainly is this F11.20, and that's opiate dependence, moderate to severe. And so this code is for patients who are being treated for opiate use disorder. And that's a code that I primarily use when I'm seeing these patients in the maintenance phase, when I'm seeing them when they've been stabilized or on maintenance. I'm seeing them every 4 weeks. I'm using this F11.20. There are variations of this code depending if they're kind of an early remission or full remission, which you can use depending on the DSM criteria, but I'm usually using this code or a variation of this code. It's important to note that opiate use disorder is one of the most misdiagnosed codes that we may use. It has long-lasting implications for the patient. So it's important that you're using this code appropriately because it can impact their ability to get insurance and get a job. So you may have noticed that this code basically is saying it's a code for opiate dependence. And opioid dependence does not mean opiate use disorder. So a person taking hydrocodone or oxycodone for a chronic pain condition may have opiate dependence, but they're maybe taking it appropriately and don't have opiate use disorder. However, this code would not be appropriate for someone you're prescribing opiates to for a chronic pain issue. This code should only be used for someone who you're treating with opiate use disorder. And that's a common source of confusion. And again, if you use this code inappropriately for someone who's being treated for chronic pain, that can have long-lasting issues with them getting life insurance or them getting a job. Same with all of the other use disorder codes. There's one for benzodiazepine dependence and one for amphetamine use dependence. Those are really used for people who have a substance use disorder and not just have dependence on the medication. For patients who are on opiates for chronic pain and not opiate use disorder, we usually use this code Z79.891, which is long-term current use of opiate analgesic. And that's for people who are appropriately taking their chronic opiate for chronic pain and don't have any signs of opiate use disorder. So that's an important thing to note, and that's it's something that I actually learned maybe just a couple years ago, because I was using this code for people who are on chronic pain too, but that's inappropriate to use that. More into the nitty-gritty of prescribing buprenorphine, as you probably all know, you need an X waiver on your DEA license to prescribe buprenorphine. Recently, because of the pandemic, mostly the requirements have changed. You don't need training to get a waiver to treat, and that way you can treat up to 30 patients, and that can be, you can actually apply for that waiver at the SAMHSA website. Previously you had to have between 8 and 24 hours of training to even get a waiver, but now you can do so without any training and treat up to 30 patients. If you want to treat more than 30 patients, you have to do additional training. That training is free. It's through this website called PCSS, which is funded through SAMHSA, and they provide online free training that you can do. They also have some in-person training that you usually can do, but that's where you can do most of your training. And after you complete that training, you can apply to see more than 30 patients. And then more education. So again, I'm always looking for ways I can get more education from the experts, from the people who are experts in this field. So PCSS, which I just mentioned, Provider Clinical Support System, funded by SAMHSA. They keep this website up to date for any additional training. That's a good resource. Here in Idaho, we have Project Echo, which is through the University of Idaho, and these are online kind of trainings. They have what they call MOUD office hours, which on first and second Thursdays of the month, which you can do over Zoom. And that basically is experts in addiction, people who have done fellowship training in addiction medicine. And that's just a time for you can ask questions and get those questions answered with them. And that's on the first and second Thursdays of every month. It's a really great resource we have with Project Echo. The American Society of Addiction Medicine, or ASAM, also a great resource. They have a lot of online trainings that have CME or CEUs. They also have a national conference every year, usually in the spring. I've attended it once, and it was a great conference. They have a lot of didactics, a lot of group discussions. It's very helpful. Lots of education there. If you're interested in getting more education and more experience, that's a great conference to attend. It usually happens every year in the spring. And those are the main resources that I would look towards to get more education, more training. And then lastly, I guess I maybe should have started this, but why should you do this? I think the reasons that I do this is because it's actually a very rewarding aspect of medicine. It's to see patients who have been struggling with opiate use disorder for decades, who've lost their families, lost their jobs, and then start them on this medication. And within months, they've really turned their life around, and they're able to go back to school, get employment, re-foster relationships with their families. That's a really rewarding aspect of the care that I give, and so you get to see that immediate kind of change in someone's life by giving this medicine. And the second thing is that medicine saves lives. It's really an important medication that has been for the last 22 odd years. We've been lucky to be able to prescribe it in the outpatient setting, and it really has changed the way we treat opiate use disorder, and it's really saving people's lives in our country to be able to offer this medication in the primary care setting.